this webinar, you know that already you got information. The topic of this webinar is the multifidus muscle and its impact on spinal health. As a physical therapist, you play a pivotal role in the management and rehab of spinal health issues. We are fortunate to have with us Mr. Michael Brantley, an expert and working as a strategic manager for Aspen Medical Products. Along with that, Mr. Justin Pepper, Associate Director of International Sales, also is joined with us. We are Aspen Medical Products is leaders in spinal health, actually, spinal braces, especially. They are the leaders in globally, and almost a 30 years old company, and they are having a presence across the globe. And thank you, Mr. Bradley, for being with us today and for your commitment to advancing knowledge in this area. Okay. So I encourage everyone to engage this activity. After the session, we have questions to Mr. Bradley. Please go ahead. Before that, a small request from my side. Please mute so that it will be very easy for you to listen Bradley's presentation. So once again, thank you for all joining with us today, and I look forward an enlightening discussion. With that, I would like to hand over the session to Mr. Brantley. Brantley, you can take it forward now. Thank you very much for giving the opportunity.
Absolutely. Thank you all for joining us tonight and this morning over here. I just wanted to give you my background really quick. I've been an educator with Aspen for 8 years. And prior to that, I was an orthopedic physical therapist. I had my doctorate in physical therapy here in the US. And I practiced in an outpatient setting for 5 years prior to transitioning to a medical device. So I can speak from the physical therapy experience, my clinical knowledge, and then try to parlay and connect existing research with clinical applications in regards to spine health, multifidus, and the efficacy of treating the spine with a lumbar brace. So from an overview, we're going to look at some different braces, traditional perspectives, and then more to what we're thinking about using in a pain management or a rehab setting. We're going to look at, does bracing result in trunk muscle weakness or atrophy of the core muscles, including the multifidus? We'll dive deep into that muscle in particular. We're going to look at research related to, is bracing effective for low back pain treatment? And then we'll look at some guidelines from the Department of Health and Human Services in the United States on their suggested use for bracing for pain. From a traditional perspective, this is what we are maybe trained on traditionally in medical school or physical therapy school. Bracing is a rigid modality that is implemented for fracture management or motion restriction or post-operative healing. This is not what we're here today to speak of. This is kind of a traditional perspective. And these are some of the older style braces that I always like to show, just as a hint that not all braces are the same. And these are a Cash brace, a Jewett brace, a Boston bivalve, and then an old classic Aspen TLSO. More to what we're speaking to in our history in this space, our company started out as a off-the-shelf or a prefabricated spinal brace company. And what we were trying to do initially was provide a traditional motion restriction type apparatus. So prior to the development of the Aspen bracing line, a lot of the braces were made custom. They were clamshell, molded plastic, hard braces. And in the year 2000, we started developing braces that could be implemented quickly off the shelf from a prefabricated mold and just try to increase efficiency of treatment and timeliness. What we saw at that period of time was patients not only had good response to our brace from a timely perspective, but we also saw low back pain relief whenever we provided compression across their trunk with the classic Aspen, and our inventors started working on a less rigid or a flexible brace that had a more compression style system. So the 2 pull tabs that you'll see in our kind of more contemporary designs, that first brace came out in 2003, and that was the first brace that was really designed by us for specifically low back pain relief. And then in 2008, our Medicare, our healthcare system approved payment for low back pain relief using our products. So we got coding and reimbursement 16 years ago here in the United States. One other delineation that I like to make regarding what a effective back brace is and what may be something that you might see at Target or a retail outlet, Amazon, those kinds of retailers. Often you'll see elastic supports, which are a stretchy banded type corset brace. We know that those aren't truly effective from a biomechanical perspective, and we'll review that really quick. So we do not recommend that style material for a low back brace. The material that's used in all of our products is an inelastic or non-elastic material. It does not stretch or deform under pressure, and that's part of the biomechanical principles when using a proper coated LSO. So I'm not going to get into all this, but we have a lot of research regarding the non-extensible LSO and what it does specifically to the spine. And what we know that it does is it increases spine stability about 14% immediately after donning the product. And this was found through biomechanical research at Yale University here in the US. So from a basic perspective, we know that the non-extensible LSO, the Aspen LSO, is effective for increasing trunk stiffness or stability a certain degree, 14% in this study. And the extensible LSOs, the stretchy ones that you would find on Amazon or retailers, provide no trunk stiffness or stability. So they're ineffective from a biomechanical perspective. And this is one more slide on the same paper, but the effectiveness of the LSO depends on the design at enhancing trunk stiffness. And this is just a research paper and a few different protocols that were put in place to measure the stability effect on the spine. Essentially, a patient was fitted in a brace, whether it was the elastic style garment or the quick draw Aspen LSO, and then the Aspen LSO with different varying panels, rigid panels. We were just trying to understand how much stability impacts the spine with the brace, and we saw once again 14% increase in spine stability with the Aspen brace and 0 change in spine stability with the elastic brace. This is the most recent design. This is the Horizon belt. I only show this because I wanted to identify the pull tabs and kind of the compression system. Essentially, we have set up a little wire pulley system in the back panel. So when the patient applies force anteriorly through the quick draw pull tabs, they're going to get a little bit more tightening through a pulley system, 4-to-1 advantage. So if they present 5 pounds of force, they're going to have 20 pounds of compression through our system. This is the most clinically intriguing topic and one of the most misunderstood in regard to bracing and spine health in general. So as a physical therapist, I was trained improperly on this subject. And fortunately, a few years ago, some studies started to come out to really try to understand what is actually happening with muscle function after a spine brace is applied. So from an overview perspective, we put out a survey in 2015, and about 50% of clinicians believe that bracing causes trunk muscle atrophy. So we found that chiropractors, physical therapists, and medical doctors in the United States, half of them believe that braces could create or created muscle weakness. However, in 2017, we start to see literature come out. This is a systematic review that was published in the Spine Journal in 2017. And what this author was trying to delineate was, if we look at all of the existing research that has any interpretation on muscle function and an LSO brace is utilized, is there any correlation or measurement in which muscle weakness or muscle atrophy or cross-sectional area loss is occurring? And this author found there is absolutely no evidence to suggest that orthosis result in trunk muscle weakness. And in the same year, a different author published a meta-analysis and systematic review in the Spine Journal, unrelated to the other author. This is Takasaki, and they were looking at a similar outcome measures, the impact of continuous LSO use on trunk motor performance. And once again, they saw no negative effect, even with continuous use of an LSO for 1 to 6 months. So there were 8 studies included in this. Once again, they found no evidence that bracing has any negative effect on muscle strength or composition. And then the last paper on this subject I'm going to mention today was published in 2019 by Azadinia and PM&R. And what this article was looking at was more specific. They included chronic low back pain patients specifically, and they were instructed to wear the Aspen LSO brace continuously. These patients reported an average of wearing the brace 7.5 hours a day, and they wore the brace for 4 weeks. What they used to measure muscle function in this paper was ultrasound imaging. So the author imaged the patients day 1 and then 4 weeks out, and they were looking for any change in cross-sectional area that would indicate muscle atrophy or dependency or weakness from continuous LSO use. And once again, they found that there was absolutely no change in trunk muscle composition or function. So we are very comfortable at Aspen recommending that bracing and in relation to muscles is safe, and that if you think that there is muscle atrophy in relation to spinal bracing, that would be a misconception or a myth at this point. So I'm going to review a few papers on the subject of, is bracing effective for low back pain care, and what is the most current articles reporting on this subject. So I'm going to start a little bit older. This is an article that came out in 2009. It was published in the Spine Journal. It's written by Dr. Calmels from France. He's a PM&R physical medicine doctor. But essentially what he was looking at was low back bracing, a population of subacute low back pain patients. He had 200 patients involved in this study. Half of them received a brace and half of them did not receive a brace during their subacute low back pain phase. And what they noticed was patients that received a brace had a better also for mitigation of pain medication and oral pain medication usage. In 2014, this paper was published by a physical therapist, Dr. Morset, here in the US, published in Spine Journal. This is a nice paper because it delineates a non-brace group, a group that is using an elastic support, something that you would buy from a retail store, pharmacy, or Amazon, versus an Aspen LSO. And what this author found was a significant improvement in function in the patients that received the Aspen LSO versus the elastic support or versus no brace. So this is important to understand that, yes, maybe the Aspen brace is a little bit more expensive for the patient, but the clinical outcome justifies the expense because they're going to have a much better outcome during their traditional physical therapy treatment protocol when they incorporate an Aspen LSO, especially versus no brace or an elastic retail support. 99 patients, a third of patients were in each group in this one. And this is the last article on low back pain care before we get into the biomechanics of spine health and multifidus. But this is the most recent paper on the subject regarding non-rigid lumbar supports. Are they or are they not effective for low back pain? This is a meta-analysis published in APM&R in 2022. It included a number of papers that were looking at overall efficacy. And of course, in conclusion, they did show that bracing is efficacious for low back pain, for both disability, function, and pain. But what they could not delineate was which patients would benefit the most from a support. So would a patient with degenerative disc disease do better than a patient with an acute herniated disc versus a patient with facet joint syndrome or facet arthropathy or spondylosis? We can't identify with current research which patients may benefit more than others, but what we recommend is, from an overview perspective, we now know that lumbar bracing is effective for low back pain. It's a conservative treatment modality. It has no negative side effects. It's not going to create trunk muscle weakness. So it should be implemented as a conservative strategy for any patient that's willing to undergo that treatment. And then the last bit here. So in 2019, I had the opportunity to meet with our government, the Department of Health and Human Services here in the US. They were working on a pain management best practices publication just to identify if there's any gaps or inconsistencies in current pain care strategies to in general, limit our opioid epidemic and mitigate opioid usage here in the United States. And so I had the privilege to meet with the chair of the committee. She was an interventional pain management doctor that was leading this task force. And we discussed spinal bracing as a pain care modality. She agreed with our research and included it in this publication. So this is the first clinical practice guideline that recommends bracing, spinal bracing, as a pain care modality. So this was published in 2019. It's relatively recent. And here, even in the US, I've not met many clinicians that are aware of this, this publication or this recommendation for bracing for pain. So we're going to take a step back toward more physical therapy, kinesiology, trunk stability, biomechanical data, and just the basics of what we're trying to treat with a brace, what is actually happening with a multifidus muscle when a patient has a spine injury, and how that really relates to the modality of bracing. So from an overview perspective, we know that we have anterior and posterior trunk muscles that control, gross movement, prime movers like the rectus abdominis and the obliques anteriorly, and then also posteriorly of the rector spinae, longissimus, spinalis, iliocostalis. And then a little bit more important to our subject is the core muscles, which I consider the transverse ab and the multifidus muscle groups. So from an overview perspective, we know we have flexion, extension, anterior, anterior, posterior, posterior. So from a more specific discussion perspective, we're going to focus more on the multifidus for the last little bit here on this section. But as we become more aware of spine biomechanics and what muscles are implicated for spine stability, we've come to know that the multifidus muscle in the lumbar spine is essential for spine stabilization and stiffening the lumbar spine during motion. And it accounts for around 70% of spine stiffness. The multifidus is anatomically very close to facet joints. You can see here I've got a little purple line marking that muscle, demarcating that muscle in particular. And then one more slide on where that muscle is, and then there's a little hint on fatty atrophy, which we'll talk about here in a little bit. But deep in the spine, the lumbar multifidus, and there are three layers. There's a more superficial and deeper sections of this particular muscle that spans 1 to 3 to 4 spine segments. But once again, it's extremely important for providing spine stability, the most important muscle to stabilize and support the spine. From a EMG perspective, this is a study that was looking at muscle function in relation to motion, and these patients were fitted in a weighted vest. And what the authors were looking at is which muscles are active during which phases of motion. And it's very apparent and obvious. Obviously, the patient is put into an extension pattern and they have a 20-pound weighted vest on. You can see their abdominal muscles lines. So the rector spinae, or the rectus abdominis and the obliques are on. And then when they lean forward, the erector spinae are on. So you can see different lines of muscles kicking on and off, depending on where the patient's trunk is in space. But there's obviously one muscle here, and I have it a hint there. It's the multifidus. So the dark line that's always active throughout the entire range of motion in a healthy patient is the multifidus muscle, because once again, it's providing essential support and stability to the spine to retain fluidity and healthy motion in the spine, disc, and facet joints. Unfortunately, there is a cascade of degenerative effects that occur with the multifidus when there's a low back pain injury, and that can result in some other problems in relation to what we're going to see here in a moment. But this is one of the first papers that was really trying to identify the root cause of multifidus atrophy and how fast this can happen, what this could look like in the acute phase. So this was an animal study that was performed on piglets, but essentially what they were trying to do was create an inflammatory experimental injury to the lumbar disc and the lumbar nerve roots in these animals and try to measure, is there a outcome that changes the multifidus muscles function and cross-sectional areas. So essentially they ejected these baby pigs discs and nerve roots with an irritant, and they saw changes rapidly within the multifidus muscle. They saw rapid atrophy and fatty infiltration in that muscle within 3 days. About 1/4 or 24% of the muscle had degenerated or atrophied from that acute irritant being injected in the disc and into the nerve roots. Why is this happening? Was known as a neurological process. It's called pain inhibition, reflexive inhibition, or arthrogenic muscle inhibition. It's essentially the same process that we are all trained on that occurs in the VMO of the knee, the vastus medialis oblique muscle after a knee surgery. We know that the VMO tends to atrophy quickly, and we have to spend a lot of time rehabilitating that muscle in particular through exercise and different modalities. This is exactly the same mechanism at play in the spine. So when there's an injury to the disc or the facet joint or the nerve roots, it can result in neuromuscular patterns that result in inhibition of the multifidus and multifidus atrophy. So from an overview perspective, this top loop here is a stable spine, a healthy spine. So you have a spinal column providing proprioceptive feedback of healthy motion and control and stability to the brain and spinal column. And then once again, it's providing efferent signals to the muscles for activity to provide proper motion and stability. Once again, you have a loop. When we have an injury, unfortunately, we see an inhibition in this muscular center and a loss of that efferent drive to the muscles. So say there's an injury in the spinal column, whether it's a herniated disc, we have proprioceptive pain signals going to the brain and the spinal cord. This is in turned into an inhibited efferent signal to the muscles. The muscles lose function, they lose strength, power, and they begin to atrophy immediately. So when the muscles are atrophying, we then lose stability and motion control of the spine, which creates a degenerative process and a cascade of instability, more pain, more instability, more pain. So a more recent paper on this, and I'm not going to go through all this, but essentially Paul Hodges is the researcher that I quoted on the animal study in 2006. This is a more recent paper that he published in the Orthopedic Sports Physical Therapy Journal in 2019. And this is looking at many papers on changes in structure and function of the back muscles during low back pain. So there's a nice chart here, and it's the only part I'll speak to regarding this study, but it's just a mechanism at place, and it's a little bit more specific than the first chart I showed you on the last slide. But we know now after an acute injury, an initial lesion, we have an immediate reflexive inhibition along with nociceptive pain. So we know that there's pain stimulation. We feel that, we find discomfort in it. And that can alter the way we move and the way we think and catastrophizing our pain, which can lead to voluntary disuse of our muscles. If we become inactive because we're hurting, that's a conscious decision, but it's driven by pain. However, there's a unconscious and subconscious process, the reflex inhibition or arthrogenic muscle inhibition, that we cannot control. It's involuntary and it alters our muscles all the same. So on the right side of the chart, you see injury, reflex inhibition, altered muscle function, which reduces spine control. It changes muscle fiber composition, and which eventually leads to muscle unloading and atrophy. This process is involuntary. It occurs from a neurological mediated reflex. It's not something that we can voluntarily control. And sometimes it's hard to control or combat even with rehab exercises. And then from a duration or chronicity perspective, what is happening to the multifidus over a long period of time? So we see pain duration on the chart with the blue line over many years. So resting thickness of the multifidus changes very quickly in the acute phase, but it can also continue to degenerate over years and years and years so that it becomes less and less thick with less and less muscle function and strength. Also, a very important aspect if the patient's pain is more intense, if they have more hurt, then that will drive the muscle to atrophy quicker. So as pain intensity increases, the EMG load to the muscle also decreases. So as pain goes up, muscle function and EMG signal to the muscle is reduced. So from a radiological perspective, radiologists have been looking at this concept for a long time, and they can grade it with the amount of fatty infiltration and how much the muscle is atrophied. I don't look at these things in that manner, but I wanted to show you all that there is studies on the subject where radiographers are looking at this specifically and can grade it. These are MRI images. Along the left side, you can see fat grade 0, 1, and 2. It's just how much infiltration has occurred and how much muscle is decomposed and been replaced by fat. And then on the right side of the page, you can see a change in the composition of the muscle as it's shrinking, likely due to chronicity of pain or a patient that's had a chronic problem for quite some time. So, like I mentioned earlier on the Paul Hodges paper, we know that the muscle cannot spontaneously resolve and heal. So, what physical therapists in the U.S. have done and try to do is, invoke various different movement modalities to try to provide voluntary stimulation of the multifidus. But what is often more important or as important is trying to control the pain. So oftentimes we present, therapeutic modalities to try to inhibit the pain and therefore get a little more facilitation to the muscle. And one of those modalities is bracing, obviously, which I'll connect these dots here in a moment. But so from an acute injury and the patient goes into more chronic phase, our muscle function is not returned organically. And sometimes this inhibition of the multifidus can occur even if the pain does resolve. So there's some difficulty in getting a voluntary contraction back out of the muscle, and it needs to be assessed, and it needs to be a point of focus when we're trying to rehabilitate patients, not only to get them out of pain, but also to make sure that their spine muscle function returns to normal as well. And then this is just a narrative written by a physical therapist as well. Why does my back pain keep coming back? So once again, we know that once there's an initial injury and then there's arthrogenic muscle inhibition or pain inhibition, the multifidus does not spontaneously recover. So if it's dormant and the muscle is not functioning and it's vitally important for 70% of our spine stability, over time, patients may have more higher recurrence rates of injury because a very vital muscle is not functioning properly whenever they're doing functional activity in the future, whether that may be, doing their chores or work activities, bending and twisting. They're just more prone to further injury. So last part, little part here, I'm going to look at mechanism of action of the brace. How does the brace improve spine stability? How would that be therapeutic to a patient that has a low back injury and multifidus atrophy? So if we can understand patients that have an acute injury will therefore most likely have multifidus dysfunction or atrophy, we know that they're going to then have functional instability, a lack of stabilization in their spine. So what can we do immediately to improve their spine stability is provide them with a therapeutic, non-rigid compression style brace to improve their trunk stiffness and really guard them from trunk displacement or perturbations. So this is we should see an immediate comfort, immediate pain relief with these patients that are going to benefit from our product from a rehabilitation perspective. It should not be put it on them and take a guess whether they're going to feel better or not. Typically, I'd like to see the patient satisfied immediately with the treatment so that they feel pain relief or stability. Sometimes they say my back feels more stable, and that's comforting, or they may report that their pain score went down a couple points. That's good too. So they may have different ways of verbalizing how the brace is improving, their comfort and whatnot. But just know that you should see an immediate effect whenever the brace is done appropriately. These are the trials. A couple of them I did not speak to, but these are a few of the papers. We just had a a trial that was published last week. I forgot to mention it. It's the biggest pain management low back bracing trial to date. It goes out to a year. It's chronic low back pain patients in a pain management and physical therapy clinic setting. And essentially, they saw an enhancement or improvement in their pain score from initial assessment to 3 months, 6 months, and 1 year out. They saw a continuous improvement in their pain score. I think 42% initially, all the way at 3 months, and then a 48% improvement in their pain score at 1 year. I forgot to mention that article initially, but hopefully I'll remember it in the future. And this is the study I was talking about, the 200 patient retrospective LSO study. It was using the Horizon. It is published. It's on PubMed. It's titled Efficacy of Lumbar or Back Bracing for Chronic Low Back Pain. And it was written by Dr. Ala Abdel Sayed out of University of Wisconsin here in the United States. We do have another pain outcome study on the Arvista therapy collar, but that's a whole other subject. From a patient education perspective, this is something that Justin has access to provide education for your patient. This is something that I always make known, that we have a lot of material that is patient and provider education friendly, so it can help improve communication between the patient and the clinician regarding what you're intended to accomplish with the brace and your overall treatment perspective. I was going to stop there, if that's okay. The next section is thoracic and kyphosis and scoliosis concepts.
Yeah, really a great session, Brantley. I really appreciate the way you are explained everything in detail about the multifidus and the role, and how Aspen braces are really going to help in this condition. What is the difference between the elastic and inelastic? And I really appreciate the way you are explained that. Is there any question to him? Participant side, if you have any questions, please. Otherwise, shall we move to the other? Michael, you want to move to the other sessions, or you would like to?
Yeah, I can finish up. Would you like me to review the kyphosis information really quickly, since we have people here?
Okay. Mr. Chala, you want to ask something? Please go ahead now. Unmute and talk, please.
Hello, sir.
Hello.
Yes, how many hours patient has to wait? 24 hours, sir?
How long do they need to wear the brace?
Yeah, yes.
Yes. Okay. So in the Morissette study, the patients reported wearing the brace 2.5 hours per day. So these patients were instructed to use it during activities that would create pain flare. In the retrospective study that I mentioned, that is not referenced on this PowerPoint, the patients wore the braces 2 hours a day. So, or they were instructed to wear the braces 2 hours a day per protocol. But whenever I'm educating a patient, I will tell them they can wear the brace as much as they need to. We know that they can wear it up to 7.5 hours without it having any negative effect on their muscle function. So if they're using the brace for as little as, say an hour or up to 7 hours a day, that sounds like a very broad window, but that's okay. The patients that report the best outcomes per that study were wearing it 2.5 hours a day.
Okay, for software people, they used to sit more than 12 hours, no, sir, in India. So they can continue more than 12 hours?
They can, yeah. So what we see from these usage studies as continuous use is not going to cause a problem. The only thing that we try to keep an eye on is making sure that they don't get a rash or sleep in the brace and get a pressure sore or something like that. That's really the only clinical precaution that I always recommend is keep an eye on their skin. You know, you don't want them to wear it and sleep on it and create like a rash.
Okay. So when we are wearing this Aspen belt, so we can take drinks, water and cool
What
drinks.
was that? I'm sorry.
Right. So when we are doing activities, so with this belt, he can taking the drinks, no sir, water and cool drinks.
Oh,
So
yes.
he can take.
Yes. Yes.
Okay.
Patients can do physical therapy in the brace too. Some of the patients that have more intense pain, severe pain, they will tend to use the brace during their exercise program. It doesn't limit motion all that much. It doesn't prevent bending and extension and lateral bending that you would do
Yes.
during an exercise program. Um,
Okay, sir. Okay. Thank you, sir.
yep.
Thank you, Mr. Chala. If you have any questions, please raise your hands. I will admit one by one. Yeah, 1 minute. There is a couple of people, they are raised. 1 minute. I will allow one by one. Just a minute.
If you can read those to me, if there's a question on the chat, because I'm going to leave my
Mr. Aradhana, if you would like to, please go ahead.
Yeah, yeah.
Unmute.
My question is, can you give an example of how to strengthen multifidus?
There's a lot of resources online, but essentially what we try to do is provide extremity motion while stabilizing the core, just to try to facilitate the multifidus. So sometimes it'll look like patient lying prone and just simply extending and stabilizing their, sucking in their transverse ab and then extending their arm. And what you're trying to feel for is facilitation of that muscle. So you want to feel a contraction under your fingers. So that's the best way to understand um, if they're driving any facilitation of the muscle. There's a protocol called the Charmin. I can send this to you all, that has a more difficult exercises to get the patient to move forward with their muscle strength and progression that incorporates typically extremity motion while stabilizing the core to try to facilitate, smaller facilitation to the multifidus.
Thank you.
Yep.
The brace is without the rod support, right? It's elastic brace. LSO.
Yeah, it's the brace is inelastic. It doesn't stretch. It's not stretchy. So it's firm. And essentially the brace is there to protect the spine joints and enhance the stability that is lacking from the core muscles that are weak. So what we're trying to do is improve the stability to the spine, joints, disc, and facet joint that have a lot of nerve endings that emit a lot of pain. So we're trying to control the pain neurologically or neurophysiologically through the brace to enhance the patient's not only tolerance to exercise and function, but also enhance the patient's facilitation to their inhibited muscle group, in particular the multifidus. This can be seen with knee bracing as well. When a knee brace is employed for VMO weakness, you'll see a better outcome if the patient is using a knee brace along with their exercise for VMO atrophy in the knee.
Thank you.
Yep.
Thank you. Mrs. Janita Selvakumar, please go ahead. Please unmute and talk. Janita Selvakumar, please go ahead. I think. Okay. Is there any other question to him? Otherwise, we'll move to the next
No,
session.
sir.
No. Okay. Michael, are you comfortable to continue now for the next one?
I have to make a move here in about 5 minutes, so
Okay.
I
I
would
think we'll stop here. If you have any
yeah, I
question,
think it would be
one more
too
guy.
much to go too fast to
Sure.
do the next section, and I think it would not do it justice. It would not do
Exactly.
do it justice to go too fast. Yeah.
That's fine. I think we have one more request. Mr. Viru, if you have any, please unmute and talk to Mr. Michael.
Sir, this is Virendra, sir. Like few patients are having more pain, sir. They're frequently asking, like while sleeping, also I can wear this belt while sleeping.
Yeah, that's that is a case where I would make sure the patient is aware to check their skin for rashes when they're sleeping in the belt, because even though the brace is not rigid, it's flexible. If they sleep on it and get a little contortion in their skin, you could get a rash. So we don't have any precautions for them being asleep in the brace. We're just more concerned about their skin health whenever they are sleeping in the brace, to make sure that they're checking their skin and assessing that they don't have a rash build up. One other I didn't mention, but the braces are designed to be worn over a shirt. So we don't want the brace to contact the skin directly anyway. So make sure that the patients are wearing a t-shirt or some sort of shirt over their skin, and then the brace is on top of that. The braces are pretty slim. I don't know if you've had a chance to put your hands on them, but a lot of times ladies are sometimes more in tune with fashion and they don't want to show that they have a brace on. So they can wear just a simple garment, a t-shirt, then the brace, and then a bigger garment over top, and no one will know that they even have a brace on.
Yes, sir. Thank you, sir.
Yeah.
Viru, I think you got information. You got the answer
Yes,
from
sir.
Mr. Michael. Yeah, thank you.
Yeah.
Sir, Mr. Michael, there is one more question in the chat box actually. During RTP process, when an athlete should stop using braces?
There is no evidence on when they should discharge the brace. I would leave the brace on the treatment protocol indefinitely, because if they have a recurrent pain or a flare up, it would be worthwhile for them to revisit the bracing strategy immediately. So it just depends, I guess, on their tolerance to activities and what they feel comfortable with. If a patient is 0 out of 10 pain with their daily work and chores, then obviously they should likely discharge the brace. If the brace is providing them, a 2-point pain improvement during functional activities or work activities, I would keep using it. But from an overview perspective on pain intensity control, what we see kind of through research is about 3 to 4 points on a visual analog scale of pain relief that the brace can provide. So if a patient has 8 out of 10 pain, we should be able to get them down to a 5 with a brace. If they have a 3 out of 10 pain, we should probably get them closer to 1 or 0. But as far as them discharging the brace, I don't have any problem with them using it indefinitely. They'll likely use it less and less over time, but there is no protocol or publication that I can really reference in regards to that.
Thank you very much. I hope you got an answer from your side. Thank you.
Yep.
Thank you. 1 minute. Is there any other question? I'll check it. Is there any question to him?
No, sir.
There is no question. I think maybe Brantley, we can meet in another. I think one.
If there's any more questions, feel free to contact me via email. You have my email, and I'll get back to you as quick as I can.
That will
And
be
if
a
anyone wants,
good
if
thing.
anyone would like the presentation, the PowerPoint, I can share that through the internet as well. No problem.
Yeah, maybe recording will be available.
Yeah.
We are recording, and maybe this is available. Rogan, is it available in YouTube? Yeah. Participant, the recording of this webinar is available in our YouTube channel. We will share that link through the WhatsApp group. If you want to watch it again, you can go and watch the webinar again. Okay. So if you don't have any other questions, we can wind up now because Michael wants to leave. He wants to catch up a flight actually. Okay, in his busy schedule, I think he has accepted to host the webinar. And really, I appreciate the way you are participated and you are presented. You are given all the details in minute details about the multifidus and not only an information, and you are giving a lot of clinical evidence. Okay, so that is more important when it comes to the especially about this product braces. Clinical support, clinical evidence is the one which is going to play a major role. In that, you have done a very good job. I really appreciate. Thank you very much once again. Thank you for joining all. Thank you very much. Thank you.
Thank you, Brantley. Thank you, everyone. Have a great day.
Thank you.
Thank you, Justin.
Bye-bye.
Thanks for your support. I really appreciate it. Thank you very much. We'll see you soon. Okay. Thank you very much. Thanks to everyone.
Thank you.